So, dear all, thank you very much to the Endoscopy editorial board to select our work for publication in the journal. It was titled Diagnostic Endoscopic Submucosal Dissection for Colorectal Lesions with a Suspected Deep Invasion on Endoscopic Characterization. It was a multi-center work from the French group of work on superficial colorectal cancer. The aim of the study was to evaluate the benefits and the risk of colorectal ESD for the lesions that harbor a small area of invasive pattern within the lesion. We defined the small area by an area of less than 15 mm in size and that appeared invasive because of the presence of Kudo 5N or Sano 3B pattern within this area, whatever the global size of the lesion. We included all the lesions where an attempt of ESD was performed when this area of deep invasive pattern was present. And Adrien, who did his work to become a doctor, to get the doctor graduation in France, will present you the main results.
Hello everyone, so we managed to include 124 patients representing 126 lesions. Our results showed that when dissection was possible, we obtained an unblock rate of 96% and R0 rate of 76%. The pathology results showed that 26% of resected lesions were in fact very low risk lesions invading the submucosa on less than 1,000 microns and presenting no lymphovascular pattern nor budding and were as such considered completely cured. We could add 30 more % of lesion of low risk, meaning invading submucosa on over 1,000 microns, but without still any budding or lymphovascular pattern, lymphovascular invasion. The rate among dissected lesions were more important in lesions presenting less than 10 mm of focal deep invasive pattern.
Conclusion. Diagnostic ESD to obtain a pathology examination of the lesion in order to know which patient can be cured by endoscopic treatment and which one should have surgery could be an effective strategy because it allows to treat only endoscopically at least 26% of the patient and potentially 56% if submucosal invasion is no more an independent risk factor of lymph node metastasis. This is a safe strategy compared to surgery where morbidity is around 20% and mortality 1%, and it should become a first-line option, especially for the patient with severe comorbidities or in the rectum where the functional prognosis of the surgery is not good. Thank you very much for accepting the paper and we hope you will read it with interest. Best.